Scott Webster and I were at Einstein together.
Who's that?
Scott Webster, he's a
Okay.
PhD psychologist, he's at Einstein.
Who's global neurology?
Ah.
Find any of those new chocolate split devices?
say your name?
Hello?
Perfect.
Oh, Rene,
Yes.
go to 12:30 and then just leave some time for questions. Good morning, everybody. Good morning, everybody. Welcome to Grand Rounds. Is this on, PJ? Okay. So next week will be our final Grand Rounds for this academic year, and it'll be one of our own faculty speakers, Carl Hart, we share with the Department of Psychology. In fact, I think Carl's the chair of psychology now. They rotate the chair every 5 years because it's such a desirable position. And Carl, who's always very interesting and entertaining, will be talking about some topic related to substance abuse. Probably, I'm thinking, related to the opiate epidemic. So, and after that, we'll recess for August and then resume in September for the new academic year. A couple of announcements. So, despite what's going on in Washington, it's good that the government is operating at some level, and the NIH continues to make awards. So Jill Betty received a 5-year R01 from NIDA for a project on neurobehavioral mechanisms of choices to smoke cannabis and cannabis use disorders. Dev Devnan received a R01 from NIA for cognitive training and neuroplasticity in mild cognitive impairment. And Catherine Monk received a 5-year R01 from NICHD, that's Child and Human Development, for a study of preventing postpartum depression, a dyadic approach adjunctive to obstetric care. And also, this is the first time I think we've had one of these. Megan, excuse my pronunciation, easy for you to say. Megan Mrakrowski, who's heads the pediatric emergency room service, was a candidate and has been elected to the Columbia University Senate. So it's good to have somebody, and after that she's running for Congress, I understand. Today it's really a pleasure and kind of a special kind of occasion to have our speaker, Rene Kahn, speaking to us. And the reason I say that is because Rene are kind of like longtime friends, colleagues, and kindred scientific spirits in the areas that we've been pursuing research-wise over the course of our career. Rene is a native of the Netherlands, and he was educated there at the University of Groningen. After completing his postgraduate training, came to the United States for additional training in research, beginning at Albert Einstein, then at Mount Sinai, and because of the licensure laws, actually did a second residency training at Mount Sinai, and there was working under the then head of the, he was head of the Bronx VA, or was he chair already then? He was chair. Ken Davis, who was a prominent researcher and has risen now to where he's CEO of the hospital. After completing this, he returned to the Netherlands as the professor and chair at the University of Utrecht. And I think not just in the Netherlands, but really in the European Union, presided over the development of one of the most successful and productive departments in the EU, in which the research they did and their contributions to the scientific literature were prolific and really very significant. And they were notable in terms of their real scientific rigor, but also their multidisciplinary nature. Rene's major focus has been in schizophrenia and psychotic disorders, but he's invoked in that process the use of neuroimaging, of cognitive neuroscience and neuropsychology, genetics and pharmacology, and has been really a sort of a leader in the EU effort to work in the area of kind of psychiatric neuroscience and focus on psychotic disorders. For reasons that I won't go into, after having served 25 years there? Almost a quarter century as chair, returned to the United States with an offer from none other than Mount Sinai and his former boss, who's now is still his boss, as the chair of psychiatry at Mount Sinai. And he arrived in January. He's still getting acclimated, and he's trying to figure out the U.S. healthcare financing system. But if he can compartmentalize well enough today, we enjoy, or we'll look forward to hearing him talk about what has been his major passion over the course of his career, which is 4 decades of neuroimaging research in schizophrenia. So please join me in welcoming Dr. Rene Kahn.
Thank you very much, Jeff. It's a great pleasure to be here and to share some of the passions that you just talked about, and that was indeed neuroimaging. And when I started that was about 20 years ago, but it started with reading a paper that some of you may know that was published in 1976 in The Lancet, where Tim Crow and Eve Johnson and some others actually showed that in normal subjects, this is what the brain volume was. Actually, it's the ventricle size of the brain. And here, in patients with schizophrenia, you can see that the brain volume is actually smaller. The reason it's smaller because the ventricles are larger, and I'm sure you all know that the skull determines the size, so if you have more CSF, you have less brain volume. So that was a very important paper, because you may not understand that, and if I look around, some of you weren't even born then. But that was the time when people still thought that schizophrenia was induced by mothers who were cold and distant, and that brain abnormalities, were an anachronism in schizophrenia. They didn't understand that they would be there. So for me, this was an eye-opener that schizophrenia is, quote-unquote, an organic disorder, a disorder characterized by brain abnormalities. But not only that, this initial paper, and I'm going to use that paper to build the case for the progress over the last 40 years, was actually a very insightful paper. The first thing is you can see this is actually very few people. The second thing you can see is that it was done using a CT scan, not an MRI scan, because those hardly existed at that point. But they asked us a few very smart questions, and questions, in fact, that have driven the research over the last few decades. And the first question was, do these brain changes predispose for the, does the illness predispose for the brain changes? And even more, does the risk for this illness predispose? So to put that differently, what you could say is, do these brain changes actually, are they a result of the genetic risk that drives the schizophrenia? And I'm sure many of you know this little graph, and what it shows essentially is that the risk for schizophrenia increases with a degree of kinship. So the more genes you share with your brother or sister, or with your father or mother, the larger the chances that you will develop schizophrenia. And in general, in the population, it's about 1%, and it goes all the way up to about 50% when you are part of a monozygotic twin, meaning you share 100% of the genes. So this actually tells you two things, and I'll get to that later on. It tells you, one, that the risk of the illness is genetic, because the most powerful finding is that with the increased kinship, the risk increases. It's almost like a dose-response curve. That suggests it's highly genetic. On the other hand, the fact that this is only 50% clear here suggests that it cannot be only genetic. So the question was, again, like I said, that Tim Crow and others and Eve Johnson asked is, is the genetic risk related to the brain changes of schizophrenia? So the first question you need to ask then is the brain, the development of the brain, the size of the brain determined by genetic factors? And in fact it is. It's even more than that. Your brain size, whether you like it or not, is one of the most heritable characteristics of you, even more heritable than your height. And you can see this because what you can do, and this is studies that we conducted many years ago, that you have here the brain size of one twin, monozygotic, these are monozygotic twins, and here the brain size of the other twin, and this, as you can see, is almost a perfect correlation. It's almost one. So if you know the brain size of twin number one, you know the brain size of twin number two. They're almost identical. However, in dizygotic twins, sharing only 50% of the genes, what you see is that this is about a 45 degrees, so this is a correlation of about 0.6, maybe even less. It's about half the correlation here. So if you look at the difference, you can actually calculate the genetic relationship between brain volume, and I wrote them out here. Total brain volume is about 90% genetic, gray matter 82, and white matter 88. So this is almost in the same range. So brain volume is a highly genetic characteristic. And that's going to be very important because it drives the questions that we can address by measuring brain volume. So the next question would then be, what is the relationship between brain volume and genetics in schizophrenia? And what we did here is the largest consortium so far, where we combined data from Helsinki in Finland, and Jena, which is actually Germany, so this should be Jena, Germany. So Jena is only Finland, London, and Utrecht. And we combined, and these are the subjects. So, monozygotic discordant for schizophrenia, 51 subjects, not pairs. This is discordant with the patient, so these are all individuals. Discordant with a co-twin. These are healthy controls, large number, and dizygotic patients and dizygotic co-twins and dizygotic healthies. So this was hundreds of subjects. And what we found is that the correlation or the effect size actually driving the relationship between brain volume and schizophrenia was about 0.22, meaning that about 4% of the brain volume in schizophrenia patients is determined by their genetic risk. Is related. So about 4% of the brain volume is related by the fact that they are suffering from schizophrenia. That's how I should say it. If you look at the brain of schizophrenia, it's smaller, we'll get to that, than that of controls, and about 4% of this smallness is determined by the illness, and about a little bit less than that for white matter. But although this effect is rather small, 70% of this effect is determined by the genetic liability. And for white matter, that's actually 94%. So although the effect is not very large, the shrinkage of the brain of schizophrenia, I'll get to that later on, is related to the illness, and the variance explains is about 4%. But of that 4%, about 80% of that effect is genetically determined. This means, therefore, that a very large extent, although not total, of the brain changes that we see in schizophrenia, and I'll go into more detail later, is in fact related to the genetic risk to develop the illness. But is it all genes? And this is a little, I don't know whether anyone reads Punch. It used to be a British journal, but this actually shows that, you know, even innovativeness and creativity, because they come up with to the patent attorney with the exact same invention. So that would be really just genes. But is it just genes? And the answer is no. This is just an example, a single twin couple. Well, this is a healthy twin of the co-twin who is affected. So this is one of the twin pair who is affected with schizophrenia. Larger ventricles, as you know, larger sulci here as compared to the co-twin. So what this suggests is that what you see in the patient, and this is a monozygotic patient, at least part of a monozygotic patient, and you compare that to the monozygotic co-twin who's not ill, the illness effect in the brain is only seen in the patient. Now, actually, I used this slide when I came to Holland back in Holland in 1993. There was still the theory of the schizophrenic mother. I'm sure you know about this hypothesis, which was never actually even studied, let alone proven. But I showed them this, and I said, you know, you have to be a pretty smart mother to induce brain changes in one of your kids and not in the other. But this clearly suggests there's an environmental effect, and that it cannot all be genetic. And in fact, that was another, this is all as you can see, still the same sentence. This is the other question, and there are a few more coming, that Crow and Johnson and others asked. Well, it may be a predisposition to the illness, it may be related to the genetic risk, but is it a consequence of the illness? And that means we have to actually follow patients over time. And I think that's what, you know, most of our claim to fame has been of the studies that we've been doing, is that we were able to follow patients longitudinally over time with various intervals. And we've been able to do that in fairly large groups. These groups of controls is about 150 subjects. You can see this was published quite a few years ago, so this was assembled and recruited early in this century, and then followed up for 5 years and measured again. So this was at that time one of the largest cohorts. And what you can see here is the absolute brain volume. And you can see here controls in the whole brain volume that show a slight decrease, which is what you would expect. I'm going to show you in the next slide in more detail, and actually more depressing detail as well. And you can see that the patients start out with a lower brain volume because, you know, they were ill. This is not first episodes. Their average age was about 35. The average duration of illness about 10 years, so they already have a smaller brain. And they decrease even more over time in this 5-year period. This is especially pronounced for gray matter volume. This is, again, the absolute volume. You see some decreases in controls, about 20 cc's over 5 years. Again, 35, 40 years old. Patients start out slightly lower, but lose considerably more gray matter over those 5 years. So what this suggests is that there are progressive brain changes in schizophrenia, and this progression is mostly driven by gray matter volume loss. And this was, I think, one of the first papers showing that there is indeed a progressive loss in gray matter. Obviously, the CT scan study from Crow couldn't show that because it doesn't differentiate gray and white matter. So there is progressive loss. But now look at this. Over the years, we've been able to get together samples of over 2,000 subjects, controls, and patients. And this is the pattern that you see. And actually, this has now been published. It's not there in the journal, which is called, one of the newer Nature journals. But what we can see here is that in controls, this is the absolute volume, there's actually no change up to the age of 50. And then it goes down. And just to spare your feelings, I've cut off this slide here. But I can tell you where it ends. You all know where it ends, right? It ends at 0. Okay, but in the patients, you can see at their first scan, it already, which is about when the illness starts, it's around already considerably lower. The total brain volume is lower. But this plateau is actually missing. There is a progressive loss of brain volume. Now, you could say, how come these changes are so large? And actually in post-mortem research, the changes are much smaller. They're about 2 to 3%. And the reason is that actually this catches up with the changes in the control, in the patients. But this shows in a very large data set on various studies that we combined, all done in Utrecht, all done with the more or less the same scanner protocol, that there is progressive loss of brain tissue in schizophrenia. This is total brain, but it's mostly driven by changes in gray matter volume. And that's what we're seeing here. This is a more recent study where we were looking at various areas of the cortex. And there you can see that there is progressive loss over time in the cortex in patients with schizophrenia. So just as an interim summary, what I've shown you now is that brain volumes are highly heritable. One of the most heritable characteristics that we have, which in itself I think is an extremely interesting finding. The brain volume loss in schizophrenia is related to genetic risk, particularly the brain changes in white matter. Brain loss, and particularly of gray matter, is progressive, and it's mostly in the frontal and temporal area, which I'm going to show you a little bit later on. So another question that the authors of this Lancet paper asked is maybe it is related to a more severe and incapacitating form of the illness. And in fact, that seems to be the case. Because if you look at patients with good outcome, this is a single subject. Sorry, this is a poor outcome patient, a good outcome patient, and a control. And this is, again, a single subject. I mean, obviously not a single subject, 3 subjects. And you can see that these two actually don't differ very much. But the poor outcome patient has much larger ventricles and much more cortical loss of tissue. And here in various studies, whether we looked at the numbers of hospitalizations, of the duration of psychosis, or the negative symptoms, I'll go a little bit in more detail, of whether they were living independently or not, or whether they had more met and unmet needs. In each of these measures, what we found is that the progressive loss of brain change was actually more pronounced in the patients with a poor outcome. This is the number of hospitalizations, and this is on the y-axis, it's always brain volume, and this is brain volume change. This is, again, change in brain volume over a 5-year follow-up. This is all 5-year follow-up studies. Actually, this is not, this is 1 year. And you can see that the duration of psychosis, which was measured over time, and the patients who were actually psychotic over the 5-year follow-up. So they were followed up over 5 years. And if they were psychotic 60 out of 60 months, you can see that the brain loss was much more. This is the lateral ventricle. So increase is actually worse. So the patients who were psychotic all the time had more brain loss than the patients who actually did very well. And out of the 60 months, were only psychotic for a very brief period. So one could say that these are the treatment responders and these are the non-responders. If you look at negative symptoms, the more negative symptoms they had at 5-year follow-up, the more brain loss they had. Whether they were living independently or not, I mean, these were living independently, these were not. The patients who were not living independently had larger brain loss over time. This is a 1-year follow-up. And this is the Camberwell assessment of need. The more need they had for care and caregivers, the larger the brain volumes loss. So this again suggests that there is a relationship between outcome and brain volume loss. And then finally, the question was, and I do think it's very interesting that this question was posed almost 40 years ago. Well, maybe these brain changes are related to a cognitively incapacitating form of the illness, the dementia precox, how Kraepelin had defined it. And for that, to study that, we need first to study whether cognition and brain volume are related. Well, you know they are related. Do you know about the correlation between the two? I'll tell you. It's about 0.3. So it's not very large, explaining about 10% of the variance. But if you have a bigger brain, you're smarter. To not discourage the people with a small skull, you have to correct for height. Because otherwise, you look at your neighbor, exactly, I could see you guys already. Yeah, you have a pretty big skull, yeah. And maybe you also have a thick skull. That would be even better. But anyway, so you have to correct for height because height and skull size are actually highly related. But that's on a cross-sectional study. Longitudinally, the question was, and that hadn't been addressed up to that point, are brain changes over time related to cognition? And in fact, what we showed here in 3 groups, this is above average IQ, which is 110 and up. This is average, which is around 100, and this is 90. And these are changes in parahippocampal thickening and thinning of the frontal cortex. And these are not very old people, at least I don't think so, between 20 and 40. So these are not elderly here, right? These are fairly young people in the prime of their lives. And you can see that what happens to the parahippocampal thickening, or changes, I should say, is actually very much depending on IQ. Below average, actually there's no change. Above average, actually not that much, but above average, 110 and up. And my guess is you would all qualify in this room for that. And if you don't, you must have other very smart characteristics. So actually it increases. So the thickening is attributable to the people with above average intelligence. Here, the thinning of the frontal cortex may not be a thinning in everyone because the people with an above average IQ, again 110 and up, do not show frontal thinning. It's only being caused, on average, is being influenced by the below average and the average IQs. So, now the question is, I mean, we don't know whether this is cause and effect. It could very well be that if you have an above average IQ, you study longer, you have interesting jobs, you challenge your brain. And that's why this doesn't happen. I'm not, you know, it could very well be that actually the relationship is driven by other factors. But there is a relationship between brain changes over time and intelligence. And this is another study, and actually here what is nice that these are very large numbers. And we also have kids in here, see? 114 kids under 12, 76 between 12 and 20. So this is a very young cohort, and actually 57 over 40. And here also you can see, this is again, and now we have a smarter group, 130 and up. Oh, this is average 130, 110, and 90. And you can see this is thickening, and this is thinning. And you can see actually there is, this is thickening. Did I say this? This is thinning. So you can actually see that in the lower IQ, there is much more frontal thinning and only a little bit thickening here than, for instance, in the 110. And there's actually no or hardly no thinning in the people with an IQ of 130 and up. So again, this shows you, and this is over time, that changes in the brain are related to IQ. And this is even more striking, actually, if you look at it this way, because it's not only the changes, it's also the dynamics. And this is the surface area. Surface area is different from what I showed you here. This is the thickness, and this is the surface area. So this is, and you can see actually that kids with a very high, here we have kids or people, but this is younger people, this is kids, they actually start out with a much larger brain than the one with an IQ of 80, but there is a very dynamic change also. So we don't exactly know, we don't know whether this is a bad thing or not. But you can see that actually the changes in IQ of 90 or 80 isn't very much. It's pretty stable. But the changes in the brain related to a much higher IQ are much more dynamic. This is just to show you that the brain changes over time are related to the level of IQ. And this is, I think, very nice, because what we here did is look at the brain changes over time in a fairly young and with a follow-up of 5 years, and we could look at the correlations between brain change and the IQ measures. And you can see this is total brain. Big brain is total brain minus cerebellum, so it's about the same thing in gray matter. But you can see that for the total brain, the correlation, this is total IQ, this is verbal IQ, this is performance IQ, that actually these correlations are fairly high. So over a 5-year period, the change in IQ, because what I've just shown you in the previous slides was a single IQ measurement predicting or at least relating to the changes over time in the brain. This is measuring IQ twice and at the same time measuring brain volume twice. So this is actually a correlation between the two changes. And you can see that the change in total brain volume is related to the change in IQ, because the IQ does change a little bit. Usually it goes down. That the two are related, and this explains about 16% of the variance. That's nothing at all. So how is that in schizophrenia? This is a study, again, that was pretty unique when we did that, because one, it's a fairly large study, about 82 patients and 115 controls. And what we did here is the same what we did in the controls. We measured IQ twice in both controls and in patients, and we measured brain volume twice over a 5-year interval, 3-year interval. And you can first see that there is some loss of cortical thickness. We knew that. I mean, this has been shown time and time again, and this is highly significantly different, although there is also an extremely large overlap. And that's exactly what this is about. And what you can also see, that in the patients, this red line and the red triangles, there is a highly significant correlation here between change in IQ and change in cortical thickness. And this is actually not absent in this short time period in the controls. Now here I show you just the patients. It's the same as you see in this group, except this is magnified. And what you can see then, there is a subgroup of patients that shows really decline in brain volume and a real decline in IQ. And I think this is very relevant, because it's relevant because we all realize that this whole broad concept of schizophrenia may not be a homogeneous illness, but there may be subgroups. And this actually suggests that the so-called Kraepelinian schizophrenia, the dementia precox, whatever you want to call it, that may be just confined to this group. The group that early in the illness, I forgot to tell you, these were all first episode patients. So this was actually early on, the first 3 years of their illness, at least the first 3 years after then they had sought out psychiatric help, that there is a subgroup that may be characterized by cognitive loss and brain loss. And that may be a quote-unquote degenerative, subform of the illness. And again, just to give credit where credit is due, this was exactly what Crow and others suggested 40 years ago. Because there is this correlation, the cognitive function and ventricle size. Now this was not a longitudinal study, but actually it came out significant. And that was the only significant correlation that they could find. Not positive symptoms, not negative symptoms, but cognitive symptoms, not even age. And in fact, we have done, so I know many others do, we have done so many imaging studies and correlated them to the PAN score, which is psychosis or negative symptoms, and we never found anything. The only thing that we consistently find is a relationship between brain change over time in schizophrenia and cognitive change. And it's, yeah.
Mention whether this is general cognitive function or...
Oh, yes, thank you very much. The question is it general cognitive function or specific substance? This is general cognitive function, IQ. Now I have to say we used a few subtests of the WISE So we didn't do the whole 2-hour battery, but these subtests, 4 or 6, correlate very highly with IQ. But this is general IQ, general intelligence, also called G for the psychologists here in the room. All right, and that's the same here. So we're talking about general IQ. And that's what they say here. We're got to more of within. So they said, you know, we've seen this, we have this finding, and whatever, but we think the most important finding is that within the patient group, there's a relationship between increased ventricle size and cognitive impairment. More important than the finding of the large differences in ventricle size between patients and the controls. So that was pretty prescient. 40 years ago, they said, you know, yes, we find this difference between patients and controls, and as you may remember from the first slide, there's hardly any overlap. That has never been replicated. I mean, there's much, much more overlap, as you've seen in my own data, or our own data. But what they said and what they emphasized is probably what's our most important finding is the relationship between cognition and brain volume. And what we have added, it's not only cognition, but it's cognitive change, or IQ change, and brain change. And that may define a subgroup that we can then study and start to understand. So these three I already showed you, and so IQ change, so this total IQ is related to brain volume change, and brain volume loss, particularly in the cortex, is related to relative cognitive decline in schizophrenia, especially, at least what we find very early in the illness. So, I mean, that's what we've learned, but we've learned a few other things. And this is a meta-analysis that we published a few years ago on 18,000 subjects, about 9,000 schizophrenia patients and 9,000 healthy subjects. And what we've looked here at various measures of brain volume and compared them to the controls. So these are Z scores. So these are all significant. So this is where the controls are on 0 by definition. And this is the number of studies, not subjects. So 108 studies measured intracranial volume comparing schizophrenia to controls. And this is, and 17 studies did that in antipsychotic naive patients. So that's the beauty. If you have these large numbers, you can actually have the comparison between medication naive, antipsychotic naive, and medicated patients. This is total brain volume, gray matter, white matter, CSF. I'm going to ignore this. But what do you see here? Intracranial volume. Now, generally, people don't care. Who cares about intracranial volume, which is skull size, which is stupid, which is, you know, not very interesting, right? But what does skull size tell us? Shall I help you? The size of the brain? But it tells you something more. I'm a Mets fan. I was a Mets fan when the Mets did well, and I'm a Mets fan when the Mets don't do so well. Anyone remember Barry Strawberry or Strawberry? No. Darryl Strawberry. Yeah, exactly. Anyway, but you know, when you go to the baseball game and you bring some kids, you probably are able to fit the size of the cap of your kids when they're around the age of 13. Because the story is the brain, the brain doesn't, the skull, I should say, and therefore the brain doesn't grow anymore after the age of 13. So what this shows, is actually, if there's decreased intracranial volume, it not only shows you there's a smaller brain, but it tells you when it happened. It must have happened before the age of 13. So sometimes these very boring findings, you know, intracranial volume, you can do it with CT, you can actually literally do head size. You know, you don't need sophisticated measurements for that. So this is decreased, and this is highly significant. You know, this is the effect size. So it's a very small effect size, it's 0.2, but it's there, and it's the same in antipsychotic naive and medicated patients. So this tells you, and you know, sometimes you do a lot of sophisticated studies or whatever. I think this is one of the most important findings that we ever made. although we didn't do the stuff, it's just a meta-analysis. This suggests that schizophrenia, the brain abnormalities of schizophrenia, must start before the age of 13. That has enormous consequences in understanding the illness. And actually, I'm going to tell you, I'm not going to, we just did, I mean, there's an Enigma study coming out on bipolar illness, and what do you find in bipolar illness? What do you find in bipolar illness? No. Actually, intracranial volume is increased. And that fits extremely nicely that one of the risk factors for bipolar illness is actually increased intelligence. That's one of the risk factors for bipolar is increased intelligence, and one of the risk factors for schizophrenia is decreased intelligence. So the people who are saying schizophrenia and bipolar illness are the same, you know, I'll see you at the, you know, at the, what is it, the schoolyard or something. Okay, anyway. All right. So this is white matter, same interesting story. It's about the same size, effect size as intracranial volume, and you can see no difference, antipsychotic naive and treated. And why again is that similar to what I just showed you? This must be an early effect, this must be an early effect, and this must be an effect, as we've shown, related to the genetic risk to develop the illness. Whereas here, there is a difference, actually. The effect is larger in the medicated patients than in the medication-naive patients, here. Now, this could mean two things. It could mean, you know, these people have been ill for longer, or it could be an effect of medication. Now, that's a controversial subject that I will touch upon, but we don't know. But this is very interesting. So, actually, there are two conclusions that we can make. The brain changes in schizophrenia must occur before the age of 13 and are driven by abnormalities in the development of the white matter connections. That's what we can glean from this meta-analysis. And where are the gray matter changes? You know, just to show you, mostly in the frontal and temporal lobes, a little bit here in the parietal lobe. And this has also been found time and time again. It doesn't mean it's not in other cortical areas, but it's most pronounced in these areas. When does it start? This is just a single small study. Many more studies have been done. This is looking at ultra-high risk subjects. These are controls. These are about 13-year-old kids, 12, 13-year-old kids, followed over 5 years and rescanned after 5 years. These are controls. These are ultra-high risk kids who don't develop schizophrenia, and these are who do. And you can see here in the total brain volume, and this is the white matter volume, that actually the decrease is larger in those kids who eventually develop schizophrenia. Now this, we're certainly not the only ones who found this, many others have too. The interesting thing here is, although the numbers are very small, none of the patients that developed, or kids I should say, that developed schizophrenia actually was taking antipsychotic medication. So this suggests that these changes occur early in adolescence and are not related to the use of antipsychotic medication. Now, I already told you there are a few people who say, well, you know, all these progressive changes in gray matter that you see are related to medication. And it's unbelievably hard to pull that apart, because you understand that schizophrenia patients, they almost all are treated with antipsychotics. And so you don't know whether it's, and the higher the dose of antipsychotics, the more severe the patients are. So you don't know whether this is actually the antipsychotic itself, the duration of the illness, or the severity of the disease. Now you can try to pull it apart statistically, as these people have tried to do, but it's very tough. But there are two ways to approach this. What we've done is actually done a longitudinal study on twins discordant for schizophrenia and controls. So we looked at schizophrenia twins and their co-twin who did not develop schizophrenia and was beyond the age of risk, and in controls. And what we found here, if you look at whole brain change, that actually there was a loss of total brain volume in the patient twin, but almost to a similar degree in the non-affected co-twin. And not in the controls, at least much more than in the controls, suggesting that these changes that we see in this twin cannot be attributed either to the illness or to medication. So at least it suggests that some of the brain changes that we see are due to the genetic risk of schizophrenia. Whether this is accelerated aging, actually we did, I don't have the data here, we did publish a year ago a paper in the American Journal, that actually the changes in schizophrenia very much resemble accelerated aging. It's not qualitatively different from the changes that we see with increasing age, but it's quantitatively different. They're just more pronounced. And that actually made what you see here in these unaffected co-twins. And another way to study the effect of antipsychotics. Sorry?
What is the time interval?
5 years. Yeah.
And the average age?
The average age was, my guess is in the 40s. Yeah.
Already in the age dependent.
Yes. Yeah, and beyond the age of risk. Yes. And the other way to study the effect of antipsychotics is in bipolar illness, because there are bipolar patients with and without antipsychotics. Now, also there, you have to be careful because they may be different patients. So we did that. And this is a cross-sectional study. So this is not a longitudinal study, and as far as I know, there are not many longitudinal studies. But this is a cross-sectional study, and I just want you to look. This is patients without, not on antipsychotic and never been on them, and this is when they were in the scanner who were actually on an antipsychotic. And this is, you can see it's truncated here, but you can see here the volume of the gray matter, the white matter, the lateral ventricles, etc. There's no difference. It's not statistically, and if anything, in the antipsychotic positive patients, actually the white matter is larger, but everything is, but again, ignore it, it's not different. And here just to show you the p-values. And these are fairly large, this is a fairly large group, there's 182 subjects. Now this is again no proof that antipsychotics don't have an effect on brain volume, but at least, because you can never study it in schizophrenia, because all the schizophrenia patients have antipsychotics. But in bipolar disorder you can, and what you then find, bipolars with an antipsychotic or without have similar brain volumes, suggesting that at least in bipolar illness, antipsychotics do not change brain volume. There are a few factors that do change brain volume. One is cannabis, a study that we did quite a few years ago. And this is again a follow-up study, 5-year follow-up study in first episode schizophrenia. And this is the controls. You don't see, this is patients who didn't use cannabis, and these are patients who do use cannabis. And this is gray matter, and this is the lateral ventricle. So there is some suggestion that patients who use cannabis have larger brain volume changes. Now, that may not be due to the cannabis. It may be that they're more severe patients, although when we correct it for confounders such as severity of illness, duration of illness, etc., that didn't change any of the findings. So this may actually be an effect of cannabis. Interestingly, you know that most schizophrenia patients smoke, so we also compared, well, the smoking status actually effect of brain volume, and that hadn't been done so far. But the answer is no. I mean, obviously smoking is not good for you, but your brain doesn't shrink from it. I mean, I'm not recommending anyone smoking, but it is important for these studies because, like I said, usually we couldn't match for smoking status in the samples. The schizophrenia patients, certainly the males, smoke much, much more than the controls. And so it was important to exclude this as a confound. So to summarize, and then I'll have one more step where I think we are going. Brain volumes were highly heritable. The white matter changes are related to genetic risk. Gray matter is progressive and related to the illness, mostly pronounced in the frontal and temporal areas. Volume loss starts prior to the first psychosis. And in fact, I think the brain abnormalities related to the genetic risk start even prior to the age of 13. Cannot be entirely explained by antipsychotic medication, and is particularly pronounced in patients with cognitive decline. So where do we go from here? And just to show you a few, and this is just a sampling, but one is looking at the connectome, at the connections between the areas. Because what we've done so far is looking at gray matter, white matter, but we all realize that obviously looking at these areas of the brain is not going to tell us the whole story. We know we have to look at the connections of the brain. And that's what Martijn van der Heuvel has done from our group. And he's defined with others the Rich Club. And it's called the Rich Club because all the connections kind of merge here in these areas, in the frontal areas, and here in the occipital and parietal areas. So the hypothesis is, was that maybe these hubs, like, for instance, the hubs at, in airports, those are hubs and certain areas. I mean, that's where all the traffic comes together. And this is schematically shown. So what we've done is looked at the patient with schizophrenia. This is controls, and this is patients in the Rich Club. Those red areas, the feeder areas, which are the orange ones, and the local areas, which are the yellow ones. And you can see that the only differences were in these Rich Club areas. So that these may be particularly affected, meaning that the connections in the brain are affected. And we can also see that in siblings. This is this is control, sorry. This is siblings, this is patients. We don't see it in the feeder areas, we don't see it in the local areas. And this intermediate effect in the siblings we have seen time and time again looking at neuroimaging changes in schizophrenia. And then finally, we see it in the offspring of schizophrenia patients. So a child of a parent with schizophrenia, generally the mother, because those are those are the ones who usually have children, and those are slightly easy to recruit, but still, you can see here that again, the changes are in the Rich Club, but also in the offspring, we found them in the feeder areas and not in the local areas. And interestingly, we don't see that in bipolar illness. There's nothing going on in the Rich Club or in any of the connections in schizophrenia. So this is one way of continuing to look at the neuroimaging finding. Another one, which we're all doing here, I'm sure you're doing it here, is looking at higher resolution imaging. This is 7 Tesla. And what you can do then is actually look at the various areas of the cortex in the cortex and see which of the layers is particularly affected. And it seems to be that this was here in one of the areas. I think it's area number 4. I mean, I don't mean Broca's area, I mean layer number 4, sorry. I don't mean area, I mean layer number 4. And that's also important because we can link that to postmortem studies and we can link that to specific connections in the brain. And then finally, when I started neuroimaging research, there were people who said this, and apparently it hurt me then, so I had to come up with an answer. It took me 40 years, but anyway, or 30 years. So, initially when we did this study, said, if neuroimaging is the answer, what's the question? Well, let me tell you what the question is. So one is linking brain volume to genes, and we can do that. Not only for brain volume, but we can do that for the connections, we can do that for whatever area in the brain. And we can do that because we know that the brain volume is so extremely heritable. And this is one of the studies, I'm sure you heard of the Enigma Consortium. This is now including thousands and thousands of brains with schizophrenia. There's schizophrenia Enigma, there's bipolar, there's depression. And this is all people working together across the world. It's a major initiative. Started by Paul Thompson, who's now at the University of Southern California. And what this was found, and this is important, I think, because of what I've just told you, the genes related to the development of intracranial volume. And why is that so important? Because intracranial volume, as you surmised, is driven by brain growth. The larger the skull, the larger the brain. And actually, from very early development, skull volume, intracranial volume is driven by brain volume. So these genes may have developmental significance for schizophrenia. Another way is with machine learning is whether we can see whether using MRI will actually help us differentiate patients from controls, which is simple and stupid because we can do that better than as psychiatrists, I hope, but different within the patients. And actually they can. This is a study we've done. And machine learning, you have a testing sample and a replication sample. So the testing is in orange, the replication is in red. So this is schizophrenia. Healthy controls are in yellow and green. Bipolar patients are in blue and light blue. But what you can see is that bipolar actually differentiates pretty well from schizophrenia. Healthy controls also pretty well from schizophrenia. So this is schizophrenia. And this is healthy controls. This is bipolar in healthy controls, and this is schizophrenia. However, this should be healthy controls, not schizophrenia. You can see schizophrenia, this should be healthy controls and bipolar. You can see it doesn't work very well in differentiating bipolar from healthy controls. But what it does, with about a 70% accuracy, which clearly is not good enough, but it may very well be that at some point we're able to use neuroimaging to help differentiate patients with bipolar illness from schizophrenia, maybe patients with depression from schizophrenia, etc. It may eventually come out to be an additional tool in the diagnostics, and that could be very helpful. And in fact, there are a few studies, one of them that we're working on in the EU that is exploring this issue. The other thing is, can we look at treatment effects? And in fact, what we did here is physical exercise and non-exercise, and look at the various areas in the brain, and this is white matter. And actually, what we found that with physical exercise, there were changes in white matter connectivity and improvements in the white matter connectivity on the basis of physical exercise. Now, this has been done by a few studies. The results are not totally consistent, but what it does suggest that actually this may be an added outcome measure in therapies, and this is a very innocuous therapy, namely physical exercise. Oh, a few didn't come through, but anyway, it doesn't really matter that much, because what MRI could do also is predict the development of illness. And this is a cohort that was started a few years ago in Utah, where we are doing a follow-up on 3,000 newborns and 3,000 8-year-olds and do sequential imaging. The sequential imaging is in the 8-year-olds. Obviously, we can't do imaging yet in the very young, although hopefully we are starting doing imaging in pregnant women, so actually doing MRI imaging in the fetus. We do have approval for that. And we've just started, which I think is extremely interesting. And since this is a cohort of about 3,000 kids and babies, so 6,000 total, there will be about 60 who will develop schizophrenia. There will be many more who will develop depression and addiction and ADHD and you name it. And there, I think imaging will be helpful in understanding brain development and aberrant brain development in subjects at increased risk for developing psychiatric illness. So with that, I'd like to end. This is all studies that were done in Europe. As you know, I just came here half a year ago, and I am quick, but not that quick. So this is the people who contributed to the study so far. Thank you very much.
Rene, thank you for really a impressive display of work that you and others have done over the past several decades. Let me see if I can kind of break this down. So genes are highly associated with brain volume, and that's generic across human species. Schizophrenia genes are associated with brain volume and may produce anti-morbid, some volume reduction relative to non-schizophrenia gene possessing individuals.
Right.
And then subsequent to the manifestation of the phenotype, there is further brain volume change, mainly in gray matter in selected areas, that seems to be associated with illness severity and maybe particularly cognition.
Right.
I got that
That's
right?
an excellent summary. Couldn't have done it better. You really paid attention.
I've been paying attention to your talk. Okay, final question then is, which it begs, can treatment modify it?
Yeah. Well, the short answer is cognition, it cannot so far. And that may be the drive. I mean, we don't have medication that specifically targets cognition in schizophrenia, as you well know. We're trying, but we haven't been successful. I think in the psychosis, the answer is yes. And I think what it does suggest that treating psychosis, and actually you've shown that in one of the earlier papers with olanzapine versus haloperidol, that actually a better outcome in psychotic symptoms, so less psychotic symptoms, improvement in psychotic symptoms is actually related to less brain change over time. So I think we are able, in schizophrenia patients, we are able to treat psychosis. Are we able to treat one of the other core symptoms of the illness, namely cognition? The answer is no. And we may have to look at totally different mechanisms, one, and the other story is maybe we have to be much early in the disease. And the model I adhere to is the MCI model of Alzheimer's disease. We know once Alzheimer's has been established, the therapies have very little value. And we may have to do the same as schizophrenia, and that's why I think if we really want to understand and intervene in schizophrenia and like disorders, we need to look at the second decade of life. And maybe not even use medication, but use behavioral therapies or cognitive enhancers or whatever.
Cheryl.
Thank you, Rene, for a wonderful talk. I'd like to actually add non-invasive brain stimulation and cognitive remediation to the cognitive effects. There are some good data to support that. I had a question about the unaffected co-twins.
Yeah.
Because it seems like they have some of the neural changes.
Yeah.
They're intermediate with Rich Club. They have some gray matter volume decrease, but they don't have schizophrenia.
Yes.
What do they have? I mean,
Yeah.
it seems to me that defining these non-affected co-twins, at least they don't have the diagnosis of schizophrenia, would be informative as to what is both necessary and sufficient to
Yes.
develop the disorder.
Very good point. One little thing there, of the slides I showed, some were siblings and some were twins, but your question remains very valid. What I didn't mention is they're discordant. Actually, I did mention it. They're discordant for schizophrenia. They're not discordant for psychiatric illness, because at least half of the co-twins do have a psychiatric problem, whether it's depression or whether it's alcohol use or whether it's anxiety. They're not healthy. So it may very well be that these changes over time are not specific for schizophrenia, although we don't see them in bipolar illness, but maybe more stress-related or like I said, more non-specific and not specific for schizophrenia. But you're right, understanding what happens in these, and then the other side of the coin, understanding about the siblings or the offspring, where actually nothing happens. So what drives their resilience is just as important. Yes.
Bill.
Yeah. Thanks. I just wanted to get back to that question of the other 50% too. It's not perhaps quite the same question as what Cheryl just asked, but what are some of the other factors, in other words? In other words, if they have exactly the same genetic makeup, are there other, you imagine mostly by other biological impingements, I don't know, during pregnant gestation or something like that?
Yeah.
What do you, or lack of stimulation after?
Yeah.
What do you think they might account for some of those?
Yeah. It's a very good question, obviously. One that would come to mind, although it is simplistic and it's an easy way out, is cannabis use, for instance, because we know that may actually induce the psychosis. So that could be it. Because, one of the problems is that most of the twins, these are not adopted away twins. Most of the twins also share the common environment. They have the same parents. They have the same food. They have the same house. They usually even went to the same school. So it's a tough question. Why does the one twin develop it and the other doesn't? And it's, one of the key questions in understanding it. And that's why I think it's so important to do very early longitudinal studies in subjects at risk, because once the illness is established, we're not only too late for the patient, but we're also too late in understanding the co-twin. And that's what we need to do.
It's mysterious, but yet it's not necessarily so mysterious. If you look at it, the genetic contribution is undeniable, but it's not a monogenic, Mendelian. It's a polygenic, a probabilistic contribution. And if you look at type 2 diabetes, if you look at essential hypertension, if you look at atherosclerotic heart disease, you can have twins that have different lifestyles, that one expresses a phenotype and the other doesn't.
No,
The thing is that
could
we
be.
know what the risk factors are for those conditions to some greater degree, and we know cannabis, and we know stress, we know maybe head trauma,
True.
but we don't know all of the contributors in mental disorders. David?
Hi, I'm just curious as to whether you looked at cannabis and nicotine for the effects on neurodegeneration. Did you look at things like obesity, diet, diabetes, and other kind of
Actually,
biological,
we-
medical factors that could?
Yes.
Because obviously the life expectancy of people with schizophrenia and the general
Sure.
health status is so much
Sure.
worse.
We just I think written and maybe even submitted the study that looked at metabolic syndrome and the brain changes, and there were more brain changes in the patients that also had metabolic syndrome. Now, that doesn't totally answer your question, but it does suggest that's an aggravating factor in the brain changes, and it's actually maybe more severe. There was also a relationship between metabolic syndrome and IQ, so there may be certainly other confounding factors or intermediate factors. And this, metabolic syndrome seems to be one of them.
Jonathan?
I'm curious to hear your comments on the slide that you showed with the antipsychotic naive versus exposure. I think on the far right you had a gigantic difference on the caudate, where it looked like it actually fully protected against change. And you
Yeah.
actually looked like the thalamus was going in an
Oh,
opposite
yeah,
direction. So what are your thoughts about regional differences?
Absolutely. No, I mean, that's very well known. I think Jeff has published on that too. I mean, antipsychotics, you induce a huge increase in the basal ganglia. So being treated with antipsychotics has a very large effect. If you discontinue, especially the typical antipsychotics, if you discontinue the antipsychotics, actually it reverses itself. That's a very well-known finding in neuroimaging.
So you think that the loss is the same, and this is just an increase that's caused by the medication. So without the medication, the loss was sort of similar. The thalamus, I think, went the opposite direction.
We'll have to go back. I can go back for you. It was the meta-analysis, right, that you're referring to? Here it is. Yeah, so here, where are we? Here, yeah.
The thalamus
So
was-
this is the antipsychotic naive. So this is a decrease, and the decrease is actually decreased by the medication. So that's what you would expect. So you get an increase or relative less decrease in the thalamus. So antipsychotics in the basal ganglia will actually increase the volume. So that's exactly that's what you see here. And you see that especially pronounced. So actually what you see, which is very interesting, then in antipsychotic naive, actually, you have reductions in the volumes of the basal ganglia. But that is attenuated by the use of antipsychotics.
Has that been described that
Yeah.
in the thalamus
Yeah.
that it gets, Jeff?
I'm not so sure about the thalamus.
Well, so certainly, well, in the thalamus,
No, I mean,
but
but I
certainly
mean-
in the caudate and the putamen.
Well, rodent studies have consistently shown that D2 antagonists will produce an upregulation of D2 receptors, and it's been morphometrically described as increased caudate volume, and it's greater in first-generation antipsychotics relative to second-generation antipsychotics. If you remove people, their volume declines. In terms of thalamus, well, you probably know better than we do. What is the dopamine receptor distribution in the thalamus?
Well, I just want to add here, you can see a very large standard error, so I'm not sure that this difference is actually significant. So I would have to go back to the original paper. But this is certainly highly significantly different. Whether this actually is different, I'm not so sure. It's only 8 studies here. So I'm not so sure whether the effect is that pronounced in the thalamus.
But it's an important point, which shows how confusing and / potentially misleading interpretations of the literature can be, because the caudate effects are an iatrogenic effect,
Right.
as opposed to the gray and white matter volume changes, which we think are disease-related.
Right.
But then on the other hand, you have individuals that are kind of detractors of the therapeutic efficacy of antipsychotic treatment, suggesting that that volume reduction that Rene's demonstrated repeatedly is also iatrogenic, which we don't agree with.
Exactly.
Yes, sir. Right. Question over here.
Clarify. It was a very exciting talk, of course.
Thank you.
Could you clarify the differences in the effects and consequences of changes in the gray matter and the white matter in terms of the research you've done with schizophrenia and you've shown us here?
Yeah.
The differences, the consequences of these
Yes.
differences in the gray and the white matter.
Absolutely. It's a very good point. Well, I think the white matter changes, and especially the connections that they represent, are a very early sign of the illness, because they're mostly there before the age of 12 and 13, and are, as I would see it, actually at the core of the risk of the illness, developing very, very early, and actually that may lead to the cognitive changes and lead to the psychosis initially. That's what we did with the connectome. The gray matter changes seem to actually follow the white matter changes and may be related to the toxic, quote unquote, toxic effect. And again, Jeff Lieberman has written a lot about that, the toxic effect of the psychosis once the psychosis has established. Now, there is about a 10-year gap between the first cognitive and social changes and the psychosis. So there is a developmental window where we could actually prevent the gray matter changes and the psychosis from developing, and with that, preventing the toxic effects in the brain.
Frank?
Hi, thank you. Wonderful talk. I was just wondering, for a lot of the, hippocampus, thalamus, a lot of these regions, when we do analyses, when we're looking at, sub-regional differences, the ICV is usually a measure of correction. And I was just wondering, like, you divide hippocampus by ICV, it's a pretty standard method. Some people use it as kind of a mixed effects model or as a covariate. I was just wondering, given this, where you had mentioned that high intelligence puts you at a risk factor for bipolar, it seems like having low ICV puts you at a risk factor for schizophrenia in the same way. What would be your thoughts on using ICV as a correct, because there have been a lot of studies that show, for example, hippocampus, there was an Enigma study that showed it was
Well, that's a very good point. You may correct your finding away. That's the point.
Right, yeah.
Yeah, no, that is true. And the interesting thing is that the whole ICV has usually been seen as you describe it. Well, we'll correct for ICV, and now it becomes interesting. Now we're going to look at the data. But we forget that the ICV itself tells us a very important story. So what you're saying is, and actually that's some of the findings, that all the other changes may not be, although the hippocampus is a different story, may not be over and above the rest. I think for the hippocampus, the changes are actually more pronounced. Even if you correct for ICV and total brain, it still comes out significant.
I don't know if everybody appreciated that, but the point that Frank was making and Rene agreed with was that if you try and standardize your measurement of a region of interest, whether it's the hippocampus or anything else, with total intracranial volume, and the illness itself is associated with intracranial volume, in the case of schizophrenia lower, in this case of bipolar greater, you may be eliminating or attenuating your true illness-related difference.
Right, exactly.
So what's the best method to standardize with, height, or should you just use absolute values?
Well, but even there, schizophrenia patients are smaller than not. So, well, I think you should do both. I think you should show both data and make exactly this point, that if you correct for intracranial or total brain volume, you may correct away your finding. I think you should do it, but, sorry? Okay. I think that's the way to do it.
Myrna?
Thank you very much. Would you use any of these findings now to initiate treatment for an individual, a young person who is at high risk but didn't show any symptoms?
The short answer is no. The somewhat longer answer is that I think the most important, and actually we as clinicians use that, the most important difference in effect is how does the child compare to his or her siblings? Because that tells you a very important story, how they've been doing. At this point, I don't think MRI is going to be helpful on an individual basis at this point, and even cognition is not going to be helpful unless we can have a trajectory. If there is a clear, and that's rarely the case, but it depends on the schooling methods, system, it depends on the teachers, but if the teacher would tell you, this is a decline in social and cognitive functioning starting around the age 12, 13, I would be worried, yes. But
So the clinical is still
yes,
the indication.
absolutely.
Andrew Dwork, can you comment on what you think at a cellular level is underlying these various genetic or disease-related effects that are being measured via the MRI? Give him the microphone before he gets up and leaves.
Well, I think that what we're seeing in terms of longitudinal effects go along with the imaging studies. In other words, we're seeing worse white matter in people who had more cognitive impairment at the beginning of the illness, 80 years before we did the autopsy on it, 70 years before we did the autopsy on them. So, so I think that what's going on cellularly, harder to say. I mean, the one thing that seems to be consistent among various findings in schizophrenia is some abnormality of process formation, abnormalities of dendrites, dendritic spines,
Right.
myelin sheaths. They're all cellular processes. They're all determined in large part by microtubules, except for the spines being determined also by actin as well as microtubules. So, I'm not sure how that translates into the imaging studies, but that's what I think is going on a cellular level.
Yeah, no, that's...
It's just, it's not inconsistent. And it also fits with a lot of the genetic data,
Right.
which show that the genes associated with illness have to do with basically synapse formation,
Right.
dendritic arborization, spine formation.
Usually what I tell my residents or PhD students, if I've learned one thing, it's that we've been looking too late in schizophrenia. The more we know about the disorder, the earlier we have to look. It's really developmental. It starts as an early developmental disorder, and maybe even earlier than the age of 12, 13.
So I asked Rene an interesting question earlier when we were talking. So Rene was educated in Europe and came here for postgraduate training, then went back and had a very successful career. Stunningly successful, a lot more successful than a lot of his European colleagues. Don't mention this in public. So I said, what, is it just that he's really a superstar, or is it that the training that he got here gave him an competitive advantage going back, or Utrecht happened to be a particularly enriched academic setting? And I'll just say Rene thought that the training that he got here was really invaluable because...
Absolutely. Yeah, no, certainly at that time, but it still holds true. Don't forget that was in the 80s and 90s, and I just said, schizophrenia was still considered to be a disorder of neglect, more or less, emotional neglect. So yeah, I learned a lot. I learned to study and to write and to, yes.
So actually, at that time, I was at Mount Sinai at the same time when we both worked under same taskmaster, who has bears a striking resemblance to Nikolai Lenin. But it literally, it just shows you the importance of the environment that you have your early experiences in this case, academic or research experiences, and who your mentors or role models are, and the effect that it has. And this was just like an N of one experiment, but the results are, I think, stunningly apparent.
Right. I was a happy guinea pig.
And he survived because of some resilience. Okay, last question I want to ask you. So this started out as a dementia precox talk, and Kreplin obviously made the sort of seminal distinction, and you've shown this nice kind of sequence of effects on people with schizophrenia, from genes to development to illness. Does the same thing hold true with people who are genetically predisposed to Alzheimer's disease? In other words, will they have, if anti-morbid, premorbidly, will they have
Yes.
some morphometric?
Well, morphometric is unbelievably difficult, but I think the Alzheimer's research, one of the most compelling and fascinating studies is this. What is it? It's not nurses. It's not nurses. It's nuns. Thank you very much. The nun study, and they analyzed their letters they wrote, and the richness of the language, or the poorness of the richness. The limited richness actually predicted Alzheimer's disease 40, 50 years later. So, and that's how I see schizophrenia as well. I mean, this is probably there very, very early on. So, but there are no imaging studies of 20-year-olds, because these nuns were in their 20s, of 20-year-olds. But my guess would be that the answer is yes, you would be able to pick it up. Yes.
Well, thanks for a fascinating presentation. And since you're local, we can have you back anytime we want. We'll continue the discussion upstairs for lunch.
All right, thank you.
People who went on to get the richness of their language, or was it the quality of their writing?
No, it was really the how many synonyms they used, not the quality of the writing, but not the handwriting, not the motor writing, but
I think you just hit on Trump's diagnosis.
I'm here to help usher you up to our lunchtime conversation.
Hi there.
Hi, how are you? Good, thanks.
How are things in post?
2 weeks into fellowship, good.